Good afternoon, ladies and gentlemen, and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your moderator, Jennifer Verma, Senior Director at the Canadian Foundation for Healthcare Improvement. Please go ahead.
Hi everyone, and welcome to today's on-call webinar, Canadian Case Studies, Improving Health and Care for Inner City and Marginalized Populations. I'm pleased to be your host today. We're also pleased to have more than 212 registrants for this session, either live or available on demand. And so for those of you who are joining us and have joined us, please continue to share a little bit about yourself, who you are, where you're from, who's joining you in the chat box. In terms of our speakers, we're pleased to have Sandra Edelman. She's a Public Health, Chronic Disease Services and Primary Care Manager with Vancouver Coastal Health. She's been working in health for about 16 years in various leadership roles. She's one of the founders of Health Connection Clinic and was awarded the BC Provincial Healthcare Hero Award and 2 People First Awards from Vancouver Coastal. Dale McMurchie is an independent consultant and president of her own company. She has expertise in planning, policy, research, evaluation, program management, and health economics. Dale was also the successful applicant to our request for proposals to produce case studies of compelling Canadian examples working in cross-sectoral action to improve health outcomes, care experience, and value for money. We're going to hear about that today. And also pleased to be joined by my colleague, Christine Micah, an improvement lead with CFHI's Patient and Citizen Engagement for Improvement portfolio. She's a Master's of Public Health student who recently supported the development and analysis of the case studies profiled on today's webinar. Also in room we have our producers, Sheena and Kelly. On today's call, we're providing simultaneous interpretation, so we invite you to participate in our chat box today in either official languages. Our objectives today, we want to focus on exemplar inner-city population health cases across Canada. I want to help understand some of the factors that have influenced the success and sustainability of these cases. Talk about how these cases are bringing about triple aim, so that improvement to health in the broadest sense of the term, so really talking about social determinants, care experience, and also value for money. And finally, we're hoping to create some connections between those who are pursuing or interested to pursue this kind of work across Canada. So starting with some background, we know that high healthcare costs are concentrated in a small minority of the population. And a 3-year study in Ontario published last year by Dr. Walter Woodchus and colleagues found that 5% of the population was accounting for about 65% of healthcare costs. And we know that improving care, health, and value for money requires different tactics for different high-cost populations. So their needs are different, and so therefore their services would be too. What this doesn't capture are sort of the high-risk, no-cost populations, or those who live for many years with unmet health need. And when you start addressing those particular needs, we know that that can often result in more upfront costs and investments, but arguably can lead to longer-lasting returns. I do want to recognize the leadership of the Institute for Healthcare Improvement in designing care that considers healthcare and value as equally essential to high-performing health systems. Importantly, triple aim thinking starts with defining quality from the perspective of someone in the population you serve. It also recognizes that healthcare, it can't do it alone. It requires working with those in the population you serve, realizing the full potential of primary health care, taking measures to support care coordination and integration, going beyond efficiency gains, we talk a lot about that in Canada, to truly realizing per capita cost reductions and focusing on prevention. All the while, it's about relying on metrics that tell you if what you're doing is delivering what you thought it would. So to put it in context, only a quarter, and I would hazard to say it's far less than that, of health outcomes are a result of the healthcare system, whereas 50% we know are due to other life factors. When the Canadian Medical Association produced this figure, it was part of a national roundtable series that they hosted on the social determinants of health. And everywhere they went, there were really key topics that came to the fore: income, housing, nutrition and food security, and early childhood development. In terms of what we can do working in the health system, This review was published last year in the Canadian Medical Association Journal by Ann Anderman, and it provides a framework and concrete actions for clinicians to address the social determinants of health as part of routine clinical practice. So at the patient level, for example, asking patients about social challenges in a sensitive, caring, and culturally appropriate way. At the practice level, involving social navigators or peer support workers. And then at the community level, forging key community-based partnerships. For CFHI's part, we recently hosted a 2-day workshop in partnership with St. Michael's Hospital in Toronto, and it convened a number of healthcare providers, patients, Indigenous leaders, among others, in a conversation about how healthcare could work in better partnership with other sectors toward better healthcare and value for money. And among some of the key themes that came out of that day, and this is a really high-level summary, we're producing a report from that event as well as a video. We also hope to see some of these themes spelled out in today's discussion. But these were some of the conversations that we had around involving those with lived experience, knowing that equity is really a part of quality, moving to reconciliation. So we know all about the truth and reconciliation work, but we should be acting on this now. Making sure we peopleize the data. So data is going to be useful only insofar as it's relatable to that human experience, and that collaboration is king. So in addition, CFHI in partnership with the Institute for Healthcare Improvement funded case studies, and I'm going to turn it directly over to Dale McMurtry now, who's going to introduce that work. Dale.
Great, thank you, Jennifer. So the case studies that I conducted, we put together a list of potential exemplar cases across Canada and selected 5 that represented various service models, types of delivery, and those that applied either formal or informal triple aim approaches to their services. And then collected information about those programs using interviews and questionnaires. And then once I put together the profiles of each of those institutions or organizations, then that was sent back to the organizations to double check that I got their stories straight. So the 5 that were included were some examples of community-based primary health care. So the Health Connection Clinic in North Vancouver, which Sandra is going to speak to in more detail once I'm done. That is a more recently formed clinic. We also included the Boyle Macaulay Health Center in Edmonton, which has been around since the 70s. We looked at a physician-led model, the Inner City Health Associates in Toronto, where physicians, often on a part-time basis, provide primary health care services in homeless shelters or drop-in centers. We looked at a specialized service, so the Health Empowered Resilient Pregnancy Program in Edmonton, which is connected with StreetWorks program that provides services and support to street-involved pregnant women with substance use issues. And finally, the Southwest Ontario Aboriginal Health Access Centre was one of our exemplar cases, and that's one of several Aboriginal health access centres across Ontario. So some of the key findings and learnings I'm going to summarize today, and the first and most important one I think was that all of these cases were examples of thinking and acting out of the box, and really were exemplars of innovative thinking and flexibility about how the programs were designed and delivered. And in the way in which they described their programs or the documentation that they provided, they constantly were learning and adapting to their environment, their clients' needs, and changing circumstances. And taking risks, and I think that Sandra will talk about that in the Health Connection Clinic in terms of the risk that they took in terms of getting their programs together. One example is the Inner City Associates Palliative Care Program for homeless. One of the physicians identified that as a glaring need in Toronto, and that you can see that it was very well received by their clients. Partnerships, sorry about that. Another really critical component, and Jennifer mentioned this earlier, was the way in which these organizations work together with other health and social services to provide their clients with the necessary resources and try to work together to use the limited resources that they had in the most efficient and effective way. And that included sharing staff and office space potentially, but it was across a continuum of really kind of working in tandem together to, referral relationships. And one of the critical components of this was the information exchange across the continuum to make sure that the clients move through the various services with the information and support that they needed. Some examples of, I'm really not doing very well with these arrows, as you can tell. Some of the examples of the partnerships, in the Boyle-Macaulay example, you can see that partnerships with HIV services that provide HIV services, services to sex trade workers, youth, indigenous population, men and women, and individuals with mental health and chronic homelessness. This is an example of the partnerships provided to us by the Her Pregnancy Program, so prenatal care, primary health care, use with treatment, substance use treatment and support. The list of partnerships that the Southwest Ontario Aboriginal Health Access Centre provided were 3 pages long. Otherwise, I'd also have highlighted it here as well. Another key characteristics of these programs were that they were client-focused, so took a whole person social determinants of health approach, and this was reflected in the variety of services and programs that they provided. And critically, the staff that I spoke to really highlighted that they met the clients where they were, be that their location where they were, or personally. So if they had a chronic condition, but their pressing issue was that they were unstably housed or an issue related to their security, those issues were dealt with first, and then they worked at the client's pace to address their health and social concerns, taking a trauma-informed and risk reduction approach, and the staff reiterated this several times when I spoke to them on the various different cases, and delivering services in a cultural safe and appropriate manner. Some examples, the Her Pregnancy Program implemented a photo voice initiative where clients were given a camera to document their experiences with their care, with the program, and to highlight some of the needs that they had, health and social needs that they had. The Southwest Ontario Aboriginal Health Access Centre provides each new client with their rights, and they're given a copy, and they're highlighted here on this slide, and they're discussed with each new client, and clients are made aware of how, if they have concerns, how they can address these. These 5 sites particularly, and on some of the others that we looked at, were also community focused, and so that the individuals that I spoke with were very well versed in the needs of their community and of vulnerable populations, and had several community-wide activities to support their population and others who may not be directly their clients. And many of them had community boards with either client representation or advisory boards. In the box, this is a snippet from the Southwest Ontario AHAC's most recent accreditation report related to community engagement, and the accreditors identified and pointed out that there was a robust commitment to engaging community, and that their programs and services were adapted to meet the various needs of their communities. And you can see in this instance where Inner City Health Associates provides services. They go to where their clients are, as I mentioned, in homeless shelters, drop-in centers, and other sites. The other key piece was that staff were amazing to speak to, compassionate individuals, and who highlighted the fact that they were deliberately working to gain the trust and respect of their clients. They pointed out to me that many of their clients had been burned in other parts of the health or social sector, and that it was their job to provide services in a safe environment and to work together with others and to provide case management. Often they were the primary care provider for these individuals and helping them navigate the rest of the system. There were a number of instances where peer support was provided by people with lived experience, and services from those with cultural knowledge, such as elders. In terms of the AAA measures, that these 5 organizations collected, all of them collected outcome information that highlighted utilization or clinical information within their services. Several did intake assessments, detailed intake assessments of their clients, and followed up annually to assess how clients were progressing themselves, but also to take a look at how the population in general were progressing based on the information that they collected. Several used validated measures of health status, so validated or well-known health status surveys and health experience surveys. Sector reports, for example, the Ontario Quality Improvement Reports, which are provided on a number of indices to Aboriginal Health Access Centres, community health centres, and family health teams in Ontario. Others collected housing, employment, personal safety data. All of the cases collected surveys, information on client experience. Some collected wait time measures, and as an example of the HER pregnancy program, undertook participatory action research. In terms of the economic impact, all of these collected information on emergency department, hospitalization, and readmission rates. Some of them also applied costs to those, a lot of them did comparisons of pre-post comparisons or annual trends. In Ontario, they collect information on resource utilization bands, and that's where clients or patients are grouped by morbidity based on their expected resource needs, which is a way to kind of adjust for acuity of individuals, and so that we're comparing like with like. And then the HER program did a study on the social return on investment, and that included costs such as income assistance, costs of housing and homelessness, addiction treatment, substance use, children's aid. And this just is a highlight of the HER pregnancy program indicators for a recent study that they did, which, as you can see, includes social outcome indicators, indicators related to empowerment and safety, as well as the health outcomes. And I'm going to turn it over now to Sandra to provide a little bit more detailed information on the Health Connection Clinic.
Good morning, everybody. It's Sandra Edelman. I don't see my slide up here at this point, so hopefully that will be, oh, there it is. So I'm speaking about one of the projects or the services that Dale just referred to, and it's the community-based primary health care for vulnerable populations, the Health Connection Clinic. We're based in on the North Shore in sort of the Metro Vancouver area. We're part of Vancouver Coastal Health, which is a very large health authority that sort of includes rural as well as urban areas, including the downtown east side, which I'm sure many of you have heard about. The highlights for this, sorry, oh, I just had some feedback. This particular clinic, how we sort of began, or our sort of the founding of the clinic, was based on the fact that on the North Shore there were unmet health needs identified by doctors and community partners, and this was for the most vulnerable, homeless, and disenfranchised members of the North Shore community. And a small working group of doctors and health authority staff was formed in 2012 to prepare a business plan for a high-needs clinic. I'm getting a lot of back noise, sorry. This particular business plan was not, I mean, basically we had no traction for the plan. We were asking for not a lot of money to develop a primary care home for vulnerable populations, but at that point there was no sort of audience within the health authority to be able to actually fund the initiative. So as a result, and because we were very committed, this small group of doctors and health authority staff, we decided to take a risk and start the program on a shoestring. And by that I mean no sustainable funding. There were a few sources of funding that we were aware of that we could access, but it was at the end of a fiscal year and there was money left over in another initiative. We asked if we could have it. We asked if we could use unused GP sessionals for the clinic, and again, they weren't dedicated to us, but there was some unused, and we accessed that. We knew that there was, or I knew that there was some underutilized space. It was a storefront type space. I asked if I could borrow that, and basically, on that, honestly, just a shoestring and the borrowed space. We then met with community partners, the homeless shelters, Canadian Mental Health Association, local community groups, and discussed what the program was going to, or the clinic would look like, and if they could actually help us staff the clinic, and particularly around the social determinants of health. So if we could have outreach workers at the clinic assisting clients in terms of accessing housing, food security, income assistance, and so on. We also, at the very beginning, because we knew this was risky, is we implemented the Triple Aim objective, and we had access to a developmental evaluator from the beginning, and we were looking at sort of trying to show evidence that we were able to improve the health of vulnerable clients, enhance the client experience, actually provide services to, or medical services, mental health and addiction services to a population that often never had access to those services or were accessing emergency departments. So obviously reducing or controlling costs was another aspect of our review. So the Health Connection Clinic basically was intended to serve unattached clients, so clients that didn't have primary care or a GP, that had complex medical, mental health, addiction, and socioeconomic challenges, and that this clinic would become their primary care home. In the early sort of days, when we opened our doors, half of the clients that were coming in from the homeless shelter and from NGOs. The emergency department doctors began referring as well, because they found this is an attractive alternative to managing very complex clients within their population. And we ended up, in terms of studies, indicating or showing that many Indigenous and vulnerable elderly clients were part of our client population. Our average age is the early 50s. The majority of the clients are male, and this is not particularly unusual, given the fact that we were dealing with the most marginalized population. We started as a drop-in clinic, and we became an appointment-based for afternoons only. We had benchmarks in terms of how many drop-ins we would expect to be able to manage on a daily basis, and we were estimating 30 minutes per client. Because these were really complex clients, the appointments then allowed the GP or the NP to work with the clients for, well over 30 minutes, sometimes hours. We also incorporated the, back, I don't know what's going on with this slide, sorry. Sorry, I don't know what happened. Okay, here I am. We also incorporated a home visiting component. We had a nurse practitioner that was doing some home visiting. We added her to the clinic for housebound clients, and including on-reserve clients with the 2 First Nations communities on the North Shore. And as I said, we were supported constantly by community services and referrals. The clinic staff now includes an NPs, GPs, and medical office assistant, social support liaison, navigator type role, and a half-time team lead. We also are an education site, so we support psychiatric, medical, and NP student placement. So in terms of the Triple Aim, from the start, as I said, we incorporated this evaluation strategy into the work that we were doing to show value and viability and to support implementation in terms of PDSA cycles, assess our successes and challenges and lessons learned, addressing social determinants of health with an equity lens, and we also developed a complexity tool for screening and monitoring clients that are coming through, and engaging patients and partners in open houses, focus groups, and interviews. And we did that consistently every 6 months for the first 2.5 to 3 years of operation. In terms of the complexity tool, it was based on a Minnesota model to assess the needs, develop care plans, and measure client and population improvement over time. That tool has actually been very helpful for us because it does indicate that, when in terms of the scoring, that the vast majority of the clients we're seeing are demonstrating complexity across the spectrum of physical or medical health challenges, mental health and addictions, as well as socioeconomic challenges to managing their health. We've, in terms of the actual sort of, this is the bread and butter of how we ended up getting funding, is by indicating that that there was a reduction in the number of ED visits for the clients that were now part of the clinic, that there was that reduction in acute admissions, alternate levels of care, length of stay, and every 6 months, as I mentioned, we had evaluation results, and we were consistently showing a reduction in all of these measures, and a significant one, and particularly around acute admissions. We did see our ED visits drop, by double digits, and then we started seeing them that they went up again, and part of that we then investigated why and what was the rationale for that, and discovered that a lot of the users of the ED that were clients of ours were had not been seen by the clinic for a few years, and because of this sort of chaotic lifestyle, some of these clients do not stay with their primary care home, or they find housing in another environment, and then we sort of lose them to the clinic. There's an estimated cost savings of about $1,100 per client, and as a result, an increase in acute capacity. But I think at the very beginning, you heard mention that there's also social value to what we're doing by actually providing primary care to a population that often is underserved. And client feedback and provider feedback has been consistently positive. The clinic is very welcoming. Clients come to socialize. They have parties. They have 12 days of Christmas. Some of our clients are visiting up to 100 times a year, and some, as I say, we'll see, and then we will lose them in terms of their transient movements, and then they may return to the clinic. So in terms of next steps, what we have been doing is preparing a business plan for the expansion of the days and hours of operation. We actually received ongoing sustainable funding last fiscal year, April, and that has been, a great bonus to the entire operation, because for the first couple of years we didn't know if we were going to be able to find additional money from 1 year or for 1 month to the next, but now we are sustainable. We're expanding, as I say, the number of days and hours of operation. We've been offering services on stat holidays, again, to reduce ED visits, and that's been very successful. We're also, because of the opioid overdose crisis, we've always provided some harm reduction services, but because we weren't open on a 7-day-a-week basis, we have not been involved in opiate replacement therapy starts. We do take patients or clients that are on maintenance, and we're trying to expand that and looking at how we could actually resource the clinic so that we could be involved in the starts of opiate replacement therapy as well, and expanding our harm reduction services. We've had probably half a dozen or more of our clients pass away in the last few years, or I guess a year and a half, in terms of the opioid overdose deaths with fentanyl, and that's obviously very upsetting to the staff that are working there. We've always engaged our patients, but we're implementing a patient advisory council to receive feedback on our operations, our services, and any other additional support that they feel that we could be offering, that somebody else could be offering, so we can advocate on their behalf.
So thanks very much, Dale. And it is Christine Micah, and it's a great segue into one of the particular areas of focus where we've looked across the different case studies at client engagement, and certainly patient and family advisory councils are one way to engage. And so with that concept in mind, the idea of client and citizen engagement isn't new, though increasingly organizations are placing greater emphasis on engagement and client-centered care in the strategic priorities, and they continue to face questions on how to do more, as they continue to face questions of how to do more with less. And so one of the frameworks that has been helpful to us at the Foundation in understanding this concept of engagement is the Carmen framework. And you'll see across the top of the continuum of engagement is sort of going more from a consultative to partnership and shared leadership. And along the vertical axis, the continuum describes engagement activities happening at 3 specific levels within your healthcare or social services setting. And so at that direct level of care, a client can be involved in making decisions about his or her own care based on what is important to them. And the majority of our analysis on the engagement piece is really at this organizational design and governance level, which you'll see in red, where patients can be involved in designing the care system and how it's organized. And so at your lower end of engagement, clients can be asked their opinion, and we've heard that from Sandra when they're doing surveys, their experience, how care is organized, etc. Clients can also participate, as we've heard, as members of an advisory council, or they can be involved in co-leading organizations' quality improvement committees, as another example. And finally, that last blue box is the notion that clients can be involved in policy-making activities across that continuum of engagement, from sharing their experience about a healthcare issue to decision-making related to work of a government agency, for example, funding health programs. And what we've learned through our work and investment in engagement is that clients bring different ideas and better results to the table that can influence health outcomes. And emerging evidence has demonstrated improvement in these outcomes as a result of engagement at all levels. And so when we were looking specifically at these case studies that Dale provided us with that high-level overview, and we've heard a bit more from Sandra, we heard about different engagement activities taking place across that spectrum of engagement. And this is really consistent about what we know about high-performing organizations. And in these organizations, they're engaging at all levels across this continuum and really tailor their engagement activities to the goal of engagement. Where organizations are struggling to achieve partnerships and shared leaderships, and is where we're seeing lots of examples among these case studies. And so they've been doing this well, and that's why we're seeing so many examples. For example, organizations have decided to use a participatory action research approach to guide program design and evaluation. And we've seen on the slides the powerful testimonial that photos and stories can bring, and is a powerful way to understand the experience and the impact of the programs that you're delivering. Other organizations are partnering with peer support workers and outreach workers who have lived experience similar to the circumstance of the clients that we're working with. And all that to say is at that high end of partnership and shared leadership does not diminish the efforts and engagement techniques that are on the lower end of the spectrum. And depending on what you're trying to accomplish, shared decision making may not be appropriate. And we've seen that in some organizations are using key informant interviews to understand the experience of their clients. Other organizations have formed advisory councils. And another practice that's gaining in popularity is having a client representative on the organization's board of directors. And finally, when organizations are seeking input, we've seen lots of examples where clients are filling out experience questionnaires and using suggestion boxes to convey how their feedback to the organization. And finally, the yellow box in this diagram is often glossed over when we talk about engagement, and it's assumed that if an organization is ready to engage, then so are their clients. However, it represents a major challenge to ensure that the voices making decisions at your table are representative of those receiving services. And Carmen describes these factors at the organizational, individual, and societal levels. And so what you're seeing on the slide is really our interpretation of the building blocks that can be put in place to support engagement and some of the examples of how these organizations have done this. And so at the individual level or client level, organizations can begin to support these building blocks for engagement by ensuring the needs of their clients are met, by building trust and actively recruiting and preparing clients to engage. And they can facilitate engagement by ensuring documentation is in plain language, assigning a resource person to navigate the engagement plan, and recognizing the contribution of clients. And at the organizational level, healthcare organizations can prepare for meaningful engagement by making an express commitment to engagement and to client-centered care. And they can live out those commitments by ensuring that no decision affecting clients are made without clients. In addition, the organizations can ensure that the engagement strategy chosen is appropriate for the desired purpose of engagement. And lastly, organizations can improve access to engagement activities by tailoring its recruitment methods and using diverse engagement strategies that enable clients to participate as much or as little as they'd like. And lastly, the societal factors along the bottom row that influence the world in which we operate. So organizations must champion engagement efforts to ensure the voice of clients is considered when making policy decisions. There's also a role for organizations to leverage existing community partnerships, which we've heard very much about in Sandra's discussion, the importance of partnerships. So consider how you might model engagement that you're expecting to see in your own organization when you're advocating for change, presenting at conferences and conducting research and lobbying. And finally, this is where we've heard over and over again, is to meet people where they are, both literally and figuratively. Engagement opportunities must be designed for involvement, engaging clients in a way that suits them. So there's no one-size-fits-all, and many case studies engage clients through existing programs and activities to seek out their feedback to determine how to define and to measure success. So a few concluding thoughts related to this particular deep dive about engagement in this work. Client engagement in health system redesign can accelerate improved population health, costs, and care. And we know that patients and clients bring new and different ideas than providers working on their own. And what we've seen from these case studies that have been selected based on their positive outcomes is that engagement activities are tailored to the goals of the engagement process and occur across all levels of the spectrum, whether it's information sharing or shared decision making. And lastly, just reinforcing the point that vulnerable populations are very willing and able to engage, but do require supports for meaningful engagement. And so at this point, I'm going to pass things over to Jen, who's going to facilitate the question and answer period.
Thanks so much, Christine. So everyone listening, this is an opportunity. If you want to post questions to either Dale, Sandra, or Christine, feel free to enter those in the chat box, and I'll read them aloud. I have a question, and Sandra, I'm going to start with you. You had mentioned, and I think so many people would be interested in this in terms of how programs and services like this get off the ground. So you'd said, on a shoestring budget, a small group of physicians and health authority staff came together, and I'm curious, what was the impetus or variety of reasons that brought that group together initially?
A good question. I'm not sure if this happens in other provinces, but in British Columbia, all the GPs have been forming divisions of family practice, and on the North Shore, there was a group that was one of the first out of the gate in terms of this division of family practice sort of collaboration. And so this was early days, 2011, 2012, when they formed. And they met and talked about what their main issues were or concerns were. Some of them were issues that the physician groups themselves would be dealing with Ministry of Health, for example, recruitment, retention. But the other area that they identified was high needs. And they basically felt that there were clients coming into clinics on the North Shore. Some of them were walk-in clinics. That the physicians felt that they were incapable of actually helping because of the complexity of the issues that were being presented. And then there were other clients coming into clinics that had no care card or had no money, had huge medical issues that, again, these doctors felt that they were not able to adequately address. And so that was an issue for them. And they came to the Health Authority, and I had been working for a number of years and chairing a North Shore Homeless Task Force, which has probably 40 member representations, municipal government, NGOs, the police, mental health, a whole sort of variety of people that were interested in sort of dealing with homelessness on the North Shore. The North Shore is a really affluent community, and there's a belief that if it's everybody's affluent, and that just is simply not the case. And there is, there are a number of people that are struggling either with absolute outright homelessness and living in the bush in our community and in camps, or there are a variety of individuals that are living at risk of homelessness, particularly seniors and now more recently families. So when they came to me with the doctors with their interest in high needs clients and access to services, it resonated because when I started chairing this task force, I recognized that we really on the North Shore did not provide health services outside of our typical community health centers. We were not focused on high needs populations or outreach, and so it was basically a partnership that was, I think its time had come, and so we formed this group, and we've been together ever since, and are quite pleased with the progress we've made.
Fantastic. Thanks so much, Sandra. And Dale, I'm curious, and I'm not sure if you have this information, but in terms of how any of the other clinics, what was the impetus that initiated these programs? Just any general thoughts from the other cases?
Sure. Well, in the case of the Boyle McCauley Center in Edmonton, and as I mentioned, it was formed in the 70s, and that was at a time when, for example, also in Ontario, the community health centers were forming as well, and that was kind of a progressive movement of healthcare providers in Ontario and across Canada formed community health centers and developed community-led boards. The Inner City Health Associates was a group of physicians who identified the need within Toronto for those individuals who were living in homeless shelters that needed support or primary care and did not have a primary care provider. And so they started the health associates, in a sense, just pulling together like-minded physicians and forming a board, and the association and organization has subsequently grown, mainly by word of mouth or it's gaining a larger profile within the city, and other physicians often who are working in academia or have a practice and work one day a week with the health associates. And her program, it was an identified need within the StreetWorks program in Edmonton. And again, much like the Health Connection Clinic, started on a shoestring with a room that was provided to them in kind and some staff, and to start the program, and subsequently as it's become more well known and shown its effectiveness, has grown and has more sustainable funding.
Thanks, Dale. Really appreciate that. I'm going to mention Tracy Rickard's comment. She's embedded researcher working in a Fredericton downtown community health center, and has a similar experience, because it sounds like what I'm hearing from Sandra and Dale is, at the end of the day, you've got a group of committed people that came together, many of whom were seeing the problem maybe from different angles, but saw an opportunity to work together to address this. And so similarly, she works at a nurse-led clinic that was established because of the commitment by nursing instructors who identified that there were vulnerable populations in downtown Fredericton who were not accessing care in the same way that others do. And so they started a little house, and they've recently moved into a new clinic that's state-of-the-art. Congratulations, that's so good to hear. And that including the clients in the process was critical to being able to provide care that met their needs. And actually, that was going to be a follow-up question, and I'll actually come back to the next question that's in here. But patient engagement and client engagement, that's one thing. And Christine walked us through, some underpinning frameworks that can help to guide that. And we already know that we can do a better job of engaging patients and families and community members and design, delivery, and evaluation of all kinds of services, not just health services. But it's challenging for people to do. We do things the way we've done them, and then when you have someone new at the table, it can be challenging, and we've actually worked with teams through that process. So I'm just curious what tips, and Christine, I'll start with you, and I'll come to you, Sandra, and Dale, you mentioned some of this, but I'll come to you as well. How do you engage a hard-to-reach population? What are some of the strategies that you've deployed or that someone can use to really involve a vulnerable or hard-to-reach population?
Yeah, thanks, Jen. And I think that's certainly a common question, and that is something that people continue to think about and are challenged by, but also really important. And if you're raising it as a challenge, it does mean you're thinking about it and thinking about it in a way that's intentional. So I'd say no matter what your audience, it really is thinking about what is the purpose or the goal of engagement and how can we reach this particular population. And from what we've heard from across this case studies as well as our work more generally in engagement with vulnerable populations really is the idea of meeting people where they are and developing questions and strategies and primarily relationships to be able to ask questions that you'll need those answers to. And I'm seeing Tracy's just typing in as well that building relationships takes time and patience. Be where they are, be non-judgmental, willing to collaborate, and meet them in the middle sometimes. And certainly we have a resources that was developed by one of our former teams that we worked with that is a guide and a handbook about working with and engaging with vulnerable populations that I'm happy to share as part of the post-webinar materials. So I think I couldn't have summarized it better than Tracy does. But Dale and Sandra, if you had specific examples or anything to add, I'd like to hear from you as well.
Yeah, perhaps we'll go to Sandra first.
Yes, thank you. Yeah, the other thing that we did in terms of trying to engage the client population is, the first thing we did is we engaged our community partners. So, I'll use the example of the homeless shelter because it's an excellent service on the North Shore. So they have outreach workers. Canadian Mental Health Association also has outreach workers. And so what we ended up doing is we worked with them to be able to access their client population. And so they were the ones, because they have the first relationship and the primary relationship with a lot of the vulnerable populations, that they were the ones bringing these folks into the clinic, and they would sit with them, they'd accompany them. So that really was one way to engage the population so that they'd come back. And then the other part, we've talked about, being respectful, being accessible, not having that institutional sort of, aura to the site that they were coming to also makes a big difference. Being storefront, not being, that I think makes a big difference. And then, obvious other things. They know they can come and they can get something to drink. We have food for them. They can take away. We have clothing. We do socialization events. We're now doing some group chronic disease management activities. And, so it's just, and we have involved, I've actually sat and gone into the waiting room during accreditation and as well during other sort of blog opportunities that we had and asked patients if they would chat with me. And so, so we'll talk about their experience and how we could do better. We have a suggestion box. So we're really sort of keen on engaging the patients and making it a really comfortable environment that they feel that they can openly discuss their, their needs, their challenges. And having said all that, I'm not going to pretend that we haven't had some clients that get really mad at us and tell us that we're not doing what they want us to do. So we're trying to engage that population as well, the ones that are more difficult to engage and that are angry for a variety of other reasons.
Very nice. Thanks, Sandra. Dale, anything you want to add?
Not really, although just to reiterate sort of two things that I observed that were common across each of the cases. And one was that the effort that the staff made to gain the trust and respect of the clients. And that was kind of, in a sense, first and foremost in the efforts that they made. And the second one was the kind of no time is the wrong time for clients to come and use the facilities, even if it's a safe place. Many of them get their mail at those programs. One has a dryer where people can dry their wet clothes. So those kind of supports and services are really critical.
Thanks so much, Dale. And I want to make sure we address this question. We've been sort of talking about it in terms of how Health Connection and these other examples got off the ground, and then also in terms of the engagement aspect. But We have a participant who's a physiotherapist in Red Deer, Alberta, and she started a rehab street clinic there. It's for vulnerable populations. It's a not-for-profit organization, and so, they're very much in knowledge acquisition mode, trying to learn what they can and looking for learning partnerships. So, Sandra, you had talked about early on the importance of triple aim thinking, and you mentioned some of your partnerships, but any particular suggestions? I'll go first to Sandra, then Dale, and I'll also mention just some of the work that Dale, you've produced, we're going to make available. I'll express when that's going to happen, because I think that will be beneficial too. But Sandra, first, any learning partnerships you'd suggest?
Well, I guess when I look at this and I see that it's a nonprofit, I think the first thing that I would be doing is approaching the sort of the I don't know how it works, but the health authority, the system to say, to basically, indicate this type of service you're providing and the benefits of it from a triple aim perspective, and either that if you're looking for funding or you're looking for referrals, you're looking for space, I'm not sure, but I would definitely go to the health services. And then in terms of, as I say, accessing that vulnerable population, it would be going to other nonprofits that already are working with that vulnerable population and making those connections and referrals back and forth.
Fantastic. Dale?
I don't really have that much to add, and it really is, I think, trying to get a feel for, who's in your neighborhood, what they're doing, who's working with others, and kind of making new friends in a sense. And there probably are existing networks that are out there and sometimes not obvious that once you find them and get plugged in can be really helpful and provide some great resources.
Fantastic. And I do think, some of the tools that many of the organizations that have participated in the Institute for Healthcare Improvements, Triple Aim, or they've recently focused that more squarely on people living with complex chronic conditions, but you'd find a lot of like minds in a collaborative or even space like that, where they start to talk about, Dale, to your point, sort of asset mapping. We can do sort of needs-based assessments, but looking at what are the assets within your community where there are other like-minded people and organizations that want to work together. And for our part, we realize we're new to this terrain, but we think it's really critical. And so we're going to make sure that the case study work that Dale has presented today in brief is going to be available in the fall. We're also producing a report that came out of the two-day event that we hosted, video, and we really want to try opportunities like today's webinar to create connections where maybe there weren't some previously. So nice to see that that's already happening. I want to mention what Madeline's saying as well, because I think we've been saying it, but it deserves to be said again, that hiring people, paying people, I think that's really important too, with lived experience, particularly from the population that you're trying to serve, can make a really big difference, and there are plenty of examples of that from these cases and other examples across the country. And I want to turn now to, because I think this is really an important point too. So much of this is about obviously addressing health inequities, improving quality of care, improving integration, but an area where people get hung up in trying to pursue triple aim is on that value for money. So Sandra, I was curious, you talked about the per client cost savings, and I'm just curious, was that a mental shift for people to be thinking about per client costs versus sort of overall program costs? If you could just delve into that a little bit more deeply.
I don't think it has been. I think, from, at the very most senior level of the health authority, the biggest issue, and, for every health authority or every health service across Canada is, that this increasing cost of acute utilization, and everybody is saying the solution is in community, but of course, there's no money in community. All the money is still going into acute. And so I do think people are starting to hear that it's no longer just sort of rhetoric. You have to actually look at community solutions so that we're not utilizing the acute setting any further. Like, we've already estimated that in Vancouver Coastal Health alone, by within the next 10, 15 years, we're going to need another 400 and some beds. Well, that's impossible. I mean, nobody can afford that, including the taxpayers. So I do think that that being able to do sort of bed savings, and that, you know, like how many beds can the Health Connection Clinic save? That's a question that I'm now being asked, right? And there are all sorts of algorithms to try to determine that. The same thing with, you know, how much money can be, you know, do we save the ED, the emergency department utilization by having a clinic like this? And people are very interested. It's return on investment. It's ROI. That's all I'm hearing now. And so I think that it's really critical that we come up with reasonable ways by which we can estimate actual cost savings, whether that's dollars or whether that's beds or whether that's ED visits. And, you know, there's lots of people now dedicating enormous amounts of time to trying to do that, and then make the case for, you know, the community services like Health Connection, but that, you know, for vulnerable populations, but other options in terms of community solutions as well, in terms of keeping people at home, you know, and letting them die at home and supporting them through that process rather than in an acute setting.
Thanks so much, Sandra, and I couldn't agree more. It's interesting because a lot of our work, we really try to demonstrate that triple aim, and like what you're describing now, I think it's not enough to even say what the savings are, but to actually, or the containment is, because we know without taking these extra steps, there aren't savings, right? An unfilled bed gets filled by someone else, but similarly, what we've been doing is we've been saying, you know, this return on investment is X amount, and that translates into, you know, 1,000 people getting off of this wait list, or these number of freed up beds, this sort of capacity, because I do think, you know, the reason why we look at this is to think about where could we better place our investments to greater meet health need. So a really important part of the equation, and I'm really excited that, you know, all of the cases that are going to be demonstrated in this casebook provide some creative means for articulating those returns alongside improving health experience and health of the population. We're going to actually head to our poll at the moment because we want to make sure that for those of you still on the line live today, you've got an opportunity to tell us how today's call experience went for you. So you're seeing those questions come up live, and you've got an opportunity to answer them. And I'll just reference, so we will be circulating the on-demand version of this call to all of you who've joined today's call live and the over 200 that have registered. We'll also be circulating via our newsletter, so we encourage you, if you're interested in receiving information about the cases that were described today, including Sandra's work and the other tremendous cases, as well as the proceedings from the event that was hosted in March 2-3, and even some of the tools that were discussed today. So we've got links to the Health Connection Clinic Complexity Assessment Tool, for example. So you'll get that as part of today's recording, but we'll also encourage you to sign up for the CFHI newsletter for some of those follow-on activities, and you can always reach out to us here at CFHI directly if there's something you're looking for that you can't find on our website. I want to thank our presenters, so Dale, Sandra, Christine, and then also our producers for hosting today's webinar. We'll look forward to the next time that we connect, and thank you to our audience for joining us today.